Drone, you start with the introductions. By the
Okay.
time we'll just figure out what is the issue.
Yes, sir. Good morning, everyone, and a very warm welcome to all participants, faculty members, and the examinees. I, Dr. Dron Bandutya, Assistant Professor at Namo Medical College, Silvassa. I'm the member of the PG Education Committee of the Psychiatric Society of West Zone. It gives me an immense pleasure to welcome you all to the 7th edition of the 4th series of our scholarly Sunday sessions hosted under the banner of IPS West Zone Psychiatric Education, PG Psychiatric Education Committee. We are deeply honored to have with us Dr. Sudhir Bhave, sir, who is the president of IPS Western Zone. Due to certain prior commitments, sir could not be here. I also welcome Dr. Sushil Gawande, our respected chairperson of the PG Education Committee, whose leadership and tireless efforts have shaped this Sunday academics ventures into meaningful learning platforms. I request Dr. Sushil, sir, to say a few words.
Am I audible, Drone?
Yes, sir.
Thank you so much, Drone. First of all, welcome to all the office bearers of PSWZ. Dr. Bhave is not there, but our honorary secretary, Dr. Abhijit Fai, is here.
Yes.
Secondly, I welcome our faculty, Dr. Janvi Kedare ma'am, for sparing Sunday for our scholarly Sunday session. At the same time, I welcome Dr. Ashish Sabu. Because of some technical problems, he's not able to join, but soon he will be with us. And I wish all the best. And we are trying to get as practical topics as possible to make your journey of MD psychiatry more fruitful and more easy. And another 2-3 sessions are left, and we will try to bring all important topics for you all. So I'm expecting wholeheartedly support and involvement of all the students who are here in the group now on the platform, and wishing our moderator Drone and the faculty all the best. Thank you so much.
Thank you so much, sir. I now welcome Dr. Abhijit Fai, sir, the Honorary Secretary of the IPS West Zone. Sir, I request you to speak a few words.
Thank you, Drone. First of all, I congratulate as well as thank PG Education Subcommittee for conducting such wonderful programs since during this tenure. The programs conducted so far were very practical, very I would say interactive, innovative, interesting, as well as very insightful. And we have received the feedback from many students that these programs they are liking so much. So I congratulate the PG Education Committee, especially Dr. Sushil Gawande sir, for such innovative programs. And we are hopeful that in future, many more such programs will be conducted. And once again, I give my best wishes for today's program also. It will also be a great success. And these subcommittee programs, we have received maximum number of participants so far. Among all the subcommittees program, this subcommittee program has received maximum participants. That is a very great thing. And thank you so much and best wishes.
Thank you so much, sir, for your kind words. I also take an opportunity to welcome the members of the PG Education Committee. I welcome you all. Now, I would like to introduce the faculty for today's session. They are the esteemed faculty for our today's session. First, sir, Ashish sir has joined.
Ashish sir is just a minute. No, he's not there, but you can go ahead.
Okay, sir. The first faculty is Dr. Ashish V. Sabu, sir. Sir has done his MD, DPM, and he's currently the professor and head of Department of Psychiatry at PDMMC Amravati. Sir has been an accomplished teacher with vast clinical experience and a sharp academic eye. He has authored several peer-reviewed publications, mentored numerous PG, and served in leadership roles in academic psychiatry. Beyond the clinic, he enjoys music and mentoring students on public speaking and presentation skills. I welcome you, sir. The second esteemed faculty for today's session is Dr. Janvi Kedare ma'am. Ma'am has done MD, DNB and DPM and currently working as an additional professor at TNMC and Viva Hospital, Mumbai. Ma'am is known for her dynamic teaching style and commitment to psychiatric education. Her areas of interest include women's mental health, community psychiatry, and academic mentorship. And she has actively led public awareness initiative and hold multiple academic posts in city and state psychiatric association. I welcome you, ma'am.
Thank you.
A special mention to all the examinees. Your commitment to participating today is truly commendable, and this session will be a stepping stone towards excellence in your academic journey. I welcome all the examinees, Dr. Sarita Gamit from Narendra Modi Medical College, Ahmedabad, Dr. Parth Haqqani from BJMC, Ahmedabad, Dr. Bhumi Jodani from MGM, Mumbai, Dr. Vipul Vania from Swimmer, Surat, Dr. Maitri Vankawala from Swimmer, Surat, Dr. Pratik Chaudhary from Swimmer, Surat, Dr. Soneri Ishanchi from TNMC and Viva Nair Hospital, Mumbai, Dr. Ridhi Donda, Narendra Modi Medical College, Ahmedabad, Dr. Rajvi Dave, Narendra Modi Medical College, Ahmedabad, Dr. Isha Gaur is also from Narendra Modi Medical College, Ahmedabad, Dr. Nikita Shidore from KIMS Karad, Dr. Anisha Patnaik from KIMS Karad, Dr. Rishita Kotla from JNMC Wardha, and Dr. Ashish Yawale from NKP SIMS Nagpur. I welcome you all examinees for this session.
Dhruv, before you start the sessions, could you just make sure you go into slideshow? Right now, I can just
Yes, ma'am. I'll
only
go into
see the
slideshow. I'll just
Yeah.
was waiting for. I'll start with the slideshow only, ma'am.
Huh.
Sushil sir, I'll start with Janvi ma'am's test.
Yes, absolutely.
The first part of we'll begin with the mock table Viva. So the first part of the psychological tests and assessment will be taken by our faculty, Dr. Janvi ma'am. Ma'am, I request you to take over and the questions, if you tell me, I'll read it out, ma'am.
Means, will you just explain the format? Because in the
Yeah.
slides, there are tests shown and there are questions written.
Yes, ma'am. Okay. So
Do
for
I
the
follow the same? Is it that I can allow some additional, I can ask some additional questions in
yes, ma'am.
addition to
Yes, ma'am.
whatever? And then,
Definitely,
of
ma'am.
course,
There is
there
no
is an
need.
answer key which we are going to give them immediately, or what?
After the answer, I'll just show the answer key, ma'am. No need to follow the
Yeah.
answer key or the question order, ma'am. You can ask
Right.
whatever you
So,
wish.
and there are teams. So,
Yes, ma'am.
how do we decide which team to answer the
I have
question?
put the question team wise only, and ma'am, the students are divided team wise. I'll call out the names, ma'am.
All right. So when I ask the question, the team will know which
Yes,
team is supposed to answer,
yes,
right?
yes, ma'am. Yes, ma'am.
Okay. So can we have the first slide, please?
Yes,
I'm
ma'am.
going to ask questions on psychological testing, on CT, MRIs, and EEG, the investigative methods that we use in psychiatry. All the best to all of you, and I'm sure this mock exam will definitely help you while preparing for your final exam. So you can see a test.
Team
Can you
1,
see it
Dr.
clearly?
Sarita Gamit and Dr. Parth Haqqani, please.
Can
Yes,
you see
ma'am.
the test clearly on the screen?
Yes, ma'am.
Okay, so what is this test? Can you name it?
Ma'am, this is the Binet Kamat test,
Okay.
and
What is it used for?
it is used for IQ assessment in children and young adults,
Mhm.
and it is Indian adaptation of Stanford Binet test, and it is both performance and verbal IQ. It gives both and full scale
Okay.
IQ.
And what are the
And
subtests or what components do you check in these?
ma'am, we check immediate memory and
Mm-hmm. All right. So when anybody, your partner wants to answer anything?
Comprehension.
Okay. Can you name a few tests that are used in this? What do you do in this test? What do you show a child? What instructions do you give to the child? Have you ever seen it being performed?
We show
You have?
object to the children and ask what it is.
Like object meaning?
Scissors, pencil.
Mm-hmm. Okay, then what else do you do? Okay. What three types of age? The next question on the slide is what three types of age does this test give? If you know, answer it. If you don't, it's all fine. It's okay. You can say we don't know. Is there any age range for which you can, or is there any range that you can use it for?
Yes, ma'am. We give in the set of 6 items, and each item gives 4 months of age till around mm, 16 years of age, 4 months of age. It increases when child can identify all the objects given. So basically, we get one is basal age, where all the items are identified. Lowest age at
Yes,
which all the items are identified, and
yes.
after which we give next set of items till that age when all the items are not identified by the child. So and
What is that known as?
name of it.
All right, never mind. And is there any formula that is required to convert the raw score to population IQ score?
Yes, ma'am. There is basal age upon CA into 100.
Basal age upon what is CA?
Uh,
Yes, Dr. Sarita, you want to add anything?
Mental age upon psychological age multiplied by 100.
Psychological age, is it? Okay. All right. Uh, can you tell me something about IQ? Okay, Drone, is there any time limit for which I can
Ma'am,
ask
we'll
questions?
keep
Tell
3 minutes,
me.
3 to 4 minutes, ma'am. Discussion per
Okay,
each.
so are you going to ring a bell or I'll keep a track of my time?
Ma'am, I'll ring a bell.
Yeah, okay.
Yeah, I'll tell you, ma'am. Yes.
What is meant by IQ?
IQ is global intelligence, in which uh, check ability of patients thinking and deal with environment.
You are
Think
telling me that,
rationally and act upon.
okay, so this is the definition of IQ or something else? Or intelligence? What is IQ is the question. We do IQ tests, right? When do we do IQ tests? We
to
advise
measure
IQ
the
tests to our patients. So when do we advise?
Uh,
Ma'am,
when
time
measure
is
the
up.
intelligence
poor
of
scholastic performance is present.
Mm-hmm.
Ma'am, time is up, ma'am.
Okay, so the time is up for the question, and the answer you began very well. Basal age, terminal age, and the third thing that it gives is mental age. Okay, and as you can see, the formula to calculate IQ using your Kamat Binay score is what is given here. Okay, so please maybe you can note it down if you don't know it, so that you can answer it later on. All right,
We move on
fine.
to the next team. Team 2,
Yes, we'll go on to the next team and the next question.
Dr. Bhumi Jodani and Dr. Vipul Wanya, please.
All right. This is again a very common psychological test which we use. So, what is it?
It
Which
is
test is
Rorschach
it?
test.
Okay.
Mm,
There are total 10 cards.
Yes.
This Rorschach test is based on the idea of free association,
Okay.
and it is a projective test, one of the projective tests.
Yes.
And
What do you mean by a projective test?
mm, that I don't know, ma'am.
Do you know, Vipul, what is a projective test?
Ma'am, in projective test, we are try to show something
Hmm.
to evaluate the patient's personality. And by this test, we are meaning to assess the personality.
Okay.
Not exact definition, I know, ma'am.
Okay. All right. I think we will leave it at that, but I think you need to know what is a projective test.
Yes,
What
ma'am.
kind of stimuli you present so that the person can project his or her emotions, conflicts onto the obscure stimulus. Remember, it's an obscure stimulus, okay, given in the card, given in any
Mm.
test that is a projective test. So this is a card from Rorschach, and as you said, there are 10 cards. Which card is it?
Um,
Can you tell me the
just
number?
black and white card, second
Card
or
number?
third, maybe.
This is the second or
Second,
third card. Okay. Uh, okay. So you mentioned black and white cards, right? So are there any colored
no,
cards also?
yes, ma'am. There
Yes,
are
ma'am.
the
There
red
are.
color cards, black and red cards, and this black and gray, black and white or black and gray. Uh,
So what is the significance of those colored cards on Rorschach?
mm, colored card.
Why do you have those colored cards? Okay. The questions on the slides also we will look at that. Can you name any other projective test?
Um, draw a person test
Yes.
or Robert apperception test. Robert apperception test.
Robert apperception test. Okay.
Apperception test. Yeah.
Okay.
And
As you correctly said, there are 10 cards. Do you know how to interpret the
yes,
results of
ma'am.
this? So, what is known as a popular response on the card? And what are the popular response? Can you name a few popular responses that you see on Rorschach cards?
Like
What is meant
how
by a popular
patient is
response?
holding the card.
What is a popular response, Bhumi?
Like emotional expression. Check.
Suppose you give the card, show the
Yes,
card
ma'am.
to 10 different people, and let's say 7 or 8 people give the same response on the card. What will it be called?
Popular
Popular
response.
Yes. And
Like
when it is an entirely new response, what is that known as? Do you know?
unique response.
No, it's not unique.
There is another
Good
term, but I
try,
can't
but it's
remember.
not unique. Pardon, Vipul?
There is another term, but I can't remember right now.
All right. So you need to know there are original responses also.
Okay.
Okay.
Original response.
Okay. There are different methods of scoring Rorschach. I don't think you need to go so much into detail, but it's good to know that there are different methods of scoring, at least two. Do you know them? Has anybody ever told you? No. Okay, fine. So let's see the answer key. Of course, it's Rorschach's ink blot test. It's the 6th card and it's known as the sex card. Well, another projective test, one of the projective tests is thematic apperception test. Okay. Draw a person test, house tree person are also projective techniques through which you understand the person better. And there are 10 cards. There are 5 black and gray, 2 black, gray, and red. And those are second and third. And there are 3 pastel colored cards, the last 3 cards. The next slide, please. So, which are the popular responses? Skin, piece of fur, sexual organs. These are the popular responses. So, Klopfer and Exner, these are the 2 most commonly used methods of scoring of Rorschach. And there are a number of others.
Ma'am,
Certain things
time is
like,
up, ma'am.
say, Petrowski's, yes, signs, these are used for organicity. And there are certain other questions which, if you had read, I think these answers will help you. And I think we will leave it at that. But you need to know Rorschach ink blot test in and out. All right, the next one, please.
Moving to the team 3, Dr. Pratik Chaudhary and Dr. Ridhi Donda. So, can you identify the tests, psychological tests on the screen?
Yes, what is it? Well, you can definitely see some pointers towards the test.
Dr. Pratik, Dr. Ridhi?
Dr. Pratik, is it? I can, okay.
Yes, yeah.
Okay.
Okay, at least tell us what is it? What can you make out of it? What kind of a test do you think it is? Pratik and Riddhi. Okay, you can see that there is a verbal component, verbal domain, perceptual domain, working memory and processing speed domain. What do you think it would suggest?
Whisk. I don't know the full form, but whisk test, I think.
All right, so WISC, okay, you don't know the full form. WISC is for children. Is this for children or this is for adults? All right, so what is WISC?
Oh, that's it.
Forget about the diagram that you or the picture that you can see. What is WISC?
It's also for the measuring of verbal, perceptual, and working domain and speech domain.
And the processing speed. Yes, I agree with you completely that it does show. So why do we need these different domains to understand? And when we measure intelligence, why is it necessary to get these different components?
To assess the his cognitive abilities.
Cognitive ability. What is the significance of calculating verbal domain and perceptual domain separately?
Verbal
Do you
domain.
make use of the difference between the verbal and the perceptual? If there is a significant difference in the scores of verbal and perceptual domains, does it suggest anything? Do you look for something in those cases?
मुझे सेकंड थर्ड एंड फोर्थ आंसर नहीं आता वेस बोली ना
Somebody else needs to put off the mic. Wonder Woman
Yes,
needs to put off the mic, I think.
ma'am, verbal comprehension subtest or perceptual reasoning is for to check ability, for general ability, to check the general ability.
Okay.
And working memory and processing speed to check full IQ, to measure. IQs.
All right. Okay. So let's go to the questions asked on the slide. We know the test, it's a WAIS, that is Wechsler's Adult Intelligence a scale. And for what age group it is used?
From 16 to 90 for adult.
90 or
Yes,
19?
90.
All right. And what are the 4 indices we already saw on in the picture itself? What is the full scale IQ?
100 plus or minus 15.
I didn't
Average
ask what is a
score.
normal average IQ. It is what is the full scale IQ? Okay. Now that you have told me what is an average IQ, can you tell me how do you define intellectual disability? Which IQ figures will tell you the level of, say, mild, moderate, severe intellectual disability?
Are you asking me a score for?
Yes, a score of IQ.
Okay, less than 20 is profound. 22. 20 to 35.
Okay.
7.
50 to 70 is mild. 35
Mild.
to around 50 is a moderate.
And
70 to 90 borderline.
70
to
to
70. 50 to 70 is a mild.
Okay.
35 to 49 is moderate.
Okay.
And 21 to 35 is a severe. And less than 20 is a profound.
Okay. And borderline is?
70 to
90.
90.
Is 90. Okay. So usually 70 to 85 is what they consider as borderline. And there is a concept of dull normal intelligence also, which then goes up to 89 to 90. All right, let's have the answers to the questions.
Ma'am, for this answers are not here. You have discussed, so we'll move ahead, ma'am.
Yeah, okay, fine. Let's go ahead.
Okay.
Next in, please. So we need to know all kinds of IQ tests. I think what we learned through the exercise is that we need to have the concept of what is an IQ test. What are the uses of an IQ test? Where is it indicated? In which conditions do we advise an IQ test? And what all diagnostic what diagnostic help can an IQ test give us? So we need to know IQ tests in detail because they are significant, very important in our clinical practice generally. Yes, the next one, please.
Team 4, Dr. Soneri Isanchi and Dr. Maitri Vankawala, please.
Okay. There is a hint in the question itself. What test is this?
Ma'am,
Good
it's
morning, ma'am.
thematic
It's a
perception test.
One person, Ishanshi.
Ma'am, it's a thematic perception test.
Okay. And I think Maitri is your partner, is it? Maitri?
yes, ma'am. Yes, ma'am.
Right. You were also saying something.
Yeah, ma'am. I was also saying the TAT.
Thematic apperception test.
Yeah.
So the next question is also written over there. What is meant by apperception?
So
Yes.
there is a picture. Yeah. There is a picture is given in this test, and we ask the person, the
No,
person
I think
to
no. Please hear the question properly, Maitri. I didn't ask you about the test. I'm asking you what is meant by the term apperception. What is meant by apperception? We'll talk about the test, but do you know what is the meaning of apperception?
It means mind's perception of itself and reflection of its own of itself, something like that.
Do you want to say anything, Maitri?
No, ma'am. I don't know the exact meaning of that.
Okay, do we have the answer to it, Drone?
Yes, ma'am.
Okay, so we'll show it a little later
Okay.
to understand. Okay, what is perception, by the way?
Perception is if a stimulus is given and what we perceive from that.
So what is the meaning of that? How do you perceive something? When a stimulus is given, how do you perceive something? What is meant by, so what is the difference between sensation and perception? What is sensation? I think that is where the basis of everything is, right? So what
Yes.
is sensation?
So, ma'am, sensation is what the sensory input is being received and registered in our brain. And
Yes.
perception is after our interpretation, what
Yes, it is the
cognitive processes.
interpretation of the sensation that is perception. So what could be a perception? Anything you can add to that?
Mm.
So think about it, okay? And how is the about test interpreted? I think that's where, Maitri, your answer comes. That you show the card and then what happens?
Yeah, so what we can understand on the basis of their answer that what are they saying, like what they see in the picture and what they perceive. And so based on that, we can understand what the thought process is going on in their mind or what is their unconscious, that conflict is going on.
Do you want to add anything, Ishanshi, as to how the test is
Yes.
interpreted? Yes.
Yes, ma'am. So, one picture is shown at a time, and then the participant, they are asked to write a story based on what the pictures that they can see in the card.
Yes.
And then we interpret the story, matlab, we like based on what is happening in the story, who is the main character, what the characters are feeling, and what is the final outcome. So based on that, we then interpret the story.
All right. Can we have the answers, please? Yes. A perception is the process by which new experiences are assimilated to and transformed by residuum of past experiences. That is why it is a projective test, right? That based on your past experiences, you are going to interpret whatever you see in front of you. And therefore, it is a perception. When a story is written, what you look for are themes. Who's the hero? What are the needs of the hero? Is the need for aggression? Is the need for approval? Is the need for power? Conception of environment, and there are different characters. Identification of this is how the test will be interpreted. What conflict comes through when we interpret, and what is the outcome of the story? What does it suggest? Whether it is positive, it is neutral, it is negative. All this tells us defense mechanisms used by the person while giving us the story. Depending on all these, the psychologist understands the conflicts that are going on within the mind of the patient, and it does help in uh, understanding the emotional conflicts in a person. Well, which disorders will you advise TAT for? Are you going to advise it for psychotic patients?
No, ma'am.
No, ma'am.
For whom will you advise it?
Ma'am, usually when we are not able to identify the stressor or the conflict, let's say
Which disorders?
in dissociative disorders, or sometimes in depression, or in children where the child is refusing to go to school and we are not able to exactly assess.
What is the version of that test known as? Do you show the
That is
same cards in children?
no, ma'am, that is CAT.
That is CAT. All right.
Ma'am, we'll move
Thank
ahead,
you.
ma'am.
Yes, Throne. Let's move
Yes,
on.
ma'am. Team 6, Team 5, sorry, Dr. Rajvi Dave and Dr. Anisha Patnaik, please.
Okay, it's clearly mentioned here what test is this. So let us understand what is the primary purpose of MCMI. Though it is written here, please read the full form and then only we'll go ahead. Who are the team members?
Dr. Rajvi and Dr. Anisha.
Okay, Rajvi and Anisha, yes. Milan Clinical Multi-Axial Inventory, right?
Ma'am, it is a more it is a shorter test. It takes less time to do.
How much time does it take?
It takes 30 minutes on an average to do.
Okay, and how many, what is the format of the test? There are cards, there are
Ma'am,
pictures.
it is a pen and paper format. True or false questions are there.
Questions are there.
Okay. So
There
it's
are
okay. How many questions are there in this?
195 questions are there.
Mm-hmm.
There are
And how does it differ from other personality assessments? Before that, which other personality assessments do you know?
Ma'am, International Personality Disorder Examination. Then
MMPI is
Yes.
MMPI, Minnesota Multi-Physic Personality
Yes.
Inventory.
Yeah. How is it different from them? From, let's say, MMPI. It is shorter. Understood. It takes less time. Anything else? Suppose you have a patient of schizophrenia and you have a personality disorder. Which one of the two will you prefer? MMPI or MC? Which one will you prefer for which disorder? MMPI and MCMI. Is there anything like that? If it's a diagnostic dilemma about a primary psychiatric disorder, which one will you prefer, MCMI or MMPI?
MCMI, no.
And let's see, I'm suspecting a personality disorder in a person. Then which test should I revise? All right, think over. What are the main scales included in MCMI 4 and how are they interpreted to assess personality pathology? By the way, is it a projective technique?
No, ma'am. It is not a
Subjective.
projective test. It is a structured test.
Subjective test.
It's a subjective or objective?
Objective test, sorry.
Objective test.
Objective test.
Why is it not projective?
Because there are no unambiguous stimuli given. There are direct questions asked to which we have to answer true or false.
Okay, let's see the main scales included in MCMI. There are personality scales. Can you go to the description of MCMI, the previous
Yes,
slide? So it does give us a diagnosis of personality disorders. And at least in clinical practice, you will observe that when you have dilemmas or when you want to establish a diagnosis of personality disorders, MCMI does do a good job at diagnosing personality disorders. Whereas MMPI does help in diagnostics of CIS1, as we used to call them on DSM-4, diagnosis of psychiatric disorders. Next one, please. Then there are personality scales, clinical syndrome scales, severe pathology scales, and how to score it. I think this is something you need to read up, and if you already know it, very good. But it does give us schizoid, avoidant, histrionic, narcissistic, borderline, antisocial, etc. some 15 personality scale. Okay, and there are clinical syndrome scales where it diagnoses more generalized anxiety, MDD, and post-traumatic stress disorder, and severe pathology also, like schizotypal, paranoid personalities, borderline. Okay, okay.
We'll move ahead, ma'am, with the next
Yeah,
team.
we will move ahead.
Dr. Nikita Shidore and Dr. Isha Gaur, please.
Yes, sir.
Okay, which test is this?
This is the MOCA test or the
Yes.
Montreal Cognitive Assessment test. It is
Yes.
used to evaluate MCI, that is mild cognitive impairment, or it can also
Mhm.
be used to identify dementia by the virtue of the scoring.
Okay, how do you do it?
It is available in different languages and for literate as well as illiterate versions as well. It is a paper pencil test, and it is also available if we go on the website in a app format. So it can also be performed on a tablet in that sense.
Right. So is it diagnostic?
It
How
is
will you best describe this test? Can you use it on a, say, large scale? There are
yes,
100 people sitting in the room. Can you do MOCA?
yes, ma'am. It can relatively be done in a shorter period of time. As
Okay.
compared to Addenbrook and other tests, it is relatively less comprehensive.
Yes, very true. So then can it be called as a diagnostic test?
Yes, ma'am, depending upon the score, if it is less
So how
than,
do you interpret it?
ma'am, a score of less than 24 is considered to be a mild cognitive impairment. We
Mm-hmm.
also give one more, add one more point if the patient is not educated, is educated less than 7th standard.
Mm-hmm.
And a score of 20 to a score of 22 to 24 is considered to be mild, and
Now you're telling me interpretation of MMSC or MOCA.
sorry, ma'am, I got confused.
You got a little mixed up, didn't you?
Yes.
All right. So I named one of the other tests that is usually used to evaluate cognition.
MMSC.
MMSC. All right. And any other, any Indian
Addenbrook,
you are aware of?
Addenbrook cognitive assessment.
Yes. All right. Any Indian scale that will that can be used even in the community to look for cognitive impairment? Will you look it up?
Yes, ma'am.
Yeah. All right.
Thank you.
Can we have the answers, please? So HMSC, MMSC, what is the difference between MMSC and HMSC?
HMSC is done in Hindi and MMSC is
That's the basic
original English.
difference. Yes, I agree. That's the Indian adaptation, isn't it?
Yes,
Of
it is the
MMSC.
Indian enough.
What is the difference? Is the test, do the items differ in any way when you conduct HMSC and MMSC? And what
Yes,
does it?
HMSC is also helpful if someone is less educated. It doesn't ask the writing questions just like MMSC.
Yes, that is very true. So what is the difference between a screening tool and a diagnostic test?
A screening tool is generally used in communities. So if we
Mm-hmm.
want to assess for high risk population, it doesn't really require skilled professional. While as a diagnostic test will probably need someone who is trained.
Can MOCA be used as a screening tool?
Yes,
See,
ma'am.
the point is that a screening tool just points towards the abnormality. It may not give you the domains that are affected in detail or the level of abnormality that is there. The score tells us that yes, there is cognitive impairment. But if you want to know how much is the impairment in executive function as against that in memory, you will have to dig further and go and do some further testing, isn't it?
Yes,
And
ma'am.
that's why
Ma'am,
MMSC,
we'll move
etc.,
ahead.
are screening tests. Yes, we go ahead.
Yes, ma'am.
Just make note of those tests that are given on the screen.
Yes, ma'am. Thank you, ma'am.
Team 7, Dr. Rishita Kotla and Dr. Ashish Shavale.
So, ma'am,
Yes,
well,
what
this
is
is
it?
called as a Stroop test, ma'am.
Good. What is it used for?
Ma'am,
It,
Stroop
What is
test
the
is a
test?
kind of,
Describe the test first. What do
ma'am,
you
this
do
is
in the
a,
test?
in
ma'am,
Stroop test, basically, we check, matlab we ask the patient to read, to tell the, to read the color. Like for if it is matlab margarine red, so we have to read what is the written rather than telling the color.
So you are asking them to read the word rather than giving the color of the word, right?
yes,
Yes.
ma'am. And it
What
also
does
is
it?
given 2 points, ma'am. So
Okay.
point
And
for
what does it test?
interpretation.
What does
This
it test?
test frontal lobe, ma'am. So this
How?
is also a part of NIMHANS neuropsychological battery too, ma'am.
How does it
So,
test frontal lobe?
ma'am,
Which cognitive abilities does it test?
ma'am, it is pretty similar to Luria battery test, Luria test, ma'am,
No,
where
no, I'm
you,
not asking you about other tests. I am asking you, how does it test frontal lobe functioning?
Reasoning.
Which
It checks the
components of
reasoning.
frontal lobe functioning you test through Stroop test?
Reasoning.
reasoning.
Reasoning? Okay, what are the frontal lobe functions?
Ma'am, frontal lobe functions are about similarity, lexical fluency, and similarity is like abstract thinking only. Then comes this Luria test, and apart from
Luria
that,
test is not the frontal lobe ability, right?
it
It
is
is one of the tests.
one of the tests, ma'am. So prehension behavior can be checked through this thing. And apart from this, go no go test is also given for the inhibitory control, ma'am.
What? Okay, so there is inhibitory control, there is attention.
Yeah, ma'am. So
what about sequencing?
Yes, ma'am.
Planning,
Sequencing.
organizing, sequencing.
Okay. All right, let's have the answer.
Would they?
All right, it's just this much in this. So what it tests is the mental flexibility. What you need to know is shifting set is also one of the functions of frontal lobe, and that is tested through Stroop test. Because even though the stimulus to your eyes is of a color, you're supposed to read. That means you're supposed to shift the set from your visual stimulus of the color to the word that is written there and to be able to read it. And that is why it reflects mental flexibility. And if frontal lobe abnormality is there, the mental flexibility is lost, and therefore you get a poorer score on this test. Okay. So these are some of the important functions
Yes.
of frontal lobe. All right. I think time to move on, right?
Yes, ma'am. Ma'am, we'll now start with the drug section by Dr. Ashish Sabu, sir,
Okay.
and
Fine,
then we'll
fine.
come back to you. Thank you,
All
ma'am.
right. Yes.
One test for the participants, please, quick. Anyone, please, the examiners don't answer. The participants can write in the chat box, please. Yes, it is a Bender-Gestalt test. Very good. It measures the visual acuity and motor integration, and this is for people like post brain damage. When you want to assess cognitive functions, we use this test, and these are the various things that we neurological dysfunction we measure in this points. Okay, Dr. Ashish sir, I welcome our second faculty for today, Dr. Ashish Sabu sir. Sir, there are 7 teams and we've allotted a drug and a questions. Sir, you can ask the same question or you can ask the any different question as well, sir.
Yeah.
Okay. Thank
So
you, sir.
let's start.
We'll start with team 1. So there are 3 minutes for, we'll take 3 minutes about for each team, sir.
Okay.
Yes. So team 1.
Okay. So which is the team one?
Sir, Dr. Sarita Gamit and Dr. Parth Akhani, please.
Okay. So let's begin with this first question. You are given a picture of a particular symbolic picture of a particular drug. So
Yes.
what does this indicate? Which drug is depicted
Yes, sir.
above picture?
This drug might possibility is as per mechanism lexiprazole, and it is unique in the sense that it is less D2 agonist and more of D3 partial agonist. So
Name of the
the
drug.
side effects breaks splitters also.
Let's make it.
Uh,
Hmm.
Hello,
Sure about it?
hello, yes sir.
Are you sure? Are you
Uh,
sure?
Sir, now I
In the table, you have given the what are the things, what are the receptors it is acting on.
yes sir.
Yeah. So, yes, you want to have your opinion, Dr. Sarita?
No, sir.
Sir,
Can
other
you act?
possibility, same mechanism is
Okay. Based on whatever the kind of receptor mechanisms it is having, what kind of, which kind of disorders this drug will be used to do?
yes sir. This is mainly approved for schizophrenia.
Okay. Any other? Apart from FDA approval, what other things you can try this drug for?
We can use it as we can use in bipolar depression also, and adjuvant treatment for treatment resistant depression also as an adjuvant.
Okay. You want to have any other go for what kind of drug this can be? Okay. Let's have the answer. Okay. This is very present, and it has got it works on mainly on the D3 and D2 receptors, partial agonist, and very high affinity on D3 receptors. Okay. The other things, okay. We go to the
Yes.
next team.
Team 2, Dr. Bhumi, Dr. Vipul.
Yeah. Let's have the next question. Okay. So here one drug combination is given to you. Okay. So what is the rationale behind combining two different kinds of drugs?
This is used for depression resistant, drug resistant depression.
What is the rationale for it?
Yes.
Dr. Ashish sir, your voice is not loud enough, sir. Can you please?
Now it's okay.
Yes, sir. Dr. Bhumi, Dr. Vipul. Hello.
Yes, sir.
Vipul, if you could answer.
Ashish sir.
Me?
Don't know, sir, the rationale
Hello.
behind this
Acha, you
combination.
don't know the rationale behind. Okay. Can you just predict what could be the reason? I would give you a hint. Now, bupropion and dextromethorphan is together. Both these drugs are together. Sarita?
Synergy.
Acha. Have you heard about the cytochromes?
Yes, sir. Cytochrome 450 or
Okay. Okay, so read about cytochrome 2d6 and all. and apply the same principle. What is principle is used in bupropion dextromethorphan combination and similar to with the olanzapine fluoxetine combination. Acha, what are the major side adverse effects?
Major adverse effect, GI side effect or hypotension.
Okay. More than that, because olanzapine is
Metabolic
the
side effects. Metabolic
olanzapine
side
is
effect.
metabolic side effects. Okay.
Metabolic side effect.
Is there one side effect of one drug which is corrected by other drug? Means fluoxetine has one peculiar side effect which is corrected by olanzapine.
No idea, sir.
Okay.
No,
Fluoxetine, we give it in the morning time or at night time?
Morning times.
Morning
Why?
time. Because it interfere with the sleep.
Yes. So
Yes.
it is arousing type of a drug. So and what
Yes, sir.
olanzapine does?
Sedation.
Sedative effect.
So one side effect of fluoxetine is covered with the olanzapine.
Yes, sir. Yes.
Okay,
Okay.
sir.
Question number 3. What is the indication?
Sir, it is used in bipolar depression.
Perfect. Perfect. Very nice. Very nice. So Drone, we can go ahead.
We'll move with team 3, Dr. Pratik and Dr. Riddhi. Can you name the drug which has this mechanism?
Yes.
Sushil,
Vipul.
is there a problem with Ashish's connectivity?
I
Yeah,
think
I
yes,
have.
connection
Yeah, I have
problem.
come back.
Ah,
Yes.
he has come back.
He's a breakdown also.
Ashish
Perfect.
sir,
Perfect.
this is for team 3, and I think
Yeah,
Sushil sir
yeah,
is taking over.
yeah, yeah.
Ashish sir. Okay. Over to
Yeah.
you, Ashish sir.
Okay. Yeah. So, what is the what do you make out from these drugs? Which drug it is? And it has been a unique indication in psychiatry. What indication? You can see on the right side of the things and read the
This
drug name of the drugs.
postpartum depression FDA approved only.
Yeah. Okay. And what is the mechanism of action of this drug? How it is
IV
act?
administration.
How does this drug work?
GABA A agonist.
It's an agonist or something else?
Allosteric, a positive allosteric modulator.
Okay. Yeah. And how this drug is been given? Dosage, administration of this drug.
Starting with a 5 milligram per ml and maximum up to 60 milligram at interval of something 2 to 4 hours. Sorry, sir. No exact idea.
Okay. Your partner does have any idea?
1 milligram to 4 milligram therapeutic dose range.
Okay. So let's have the answers for this. So basically, it's like given in the dosages of from 0 to 4 hours, initially the dosage of 30 microgram per kg per hour. It's given usually in the drip form, IV infusion. Okay. And the doses are increased gradually. Okay.
Okay.
So you can note down the answers which are given over here. Okay.
We'll move ahead with
We'll go to
team
the next.
4, Dr. Soneri
Yeah.
Shanchi, Dr. Maitri.
Okay. Now you can read this is a very commonly used drugs and one of the hot favorite drug nowadays used to check you. What's so special about this particular drug? Why it is used so? Which of the psychiatric conditions it is FDA approved?
So the quetiapine is used for the mainly for schizophrenia and it is also approved for bipolar disorder. Mm,
Also for bipolar depression.
Okay.
And
Can you tell me other indications where this drug can be used apart from these FDA approved drugs?
used as an
Indication.
adjunct for treatment resistant depression as an adjunct.
Okay. This is another atypical antipsychotic drugs, right?
Yes.
Yes.
How it is different from the other drugs like olanzapine or clozapine?
So it is based on the dosage. At low dosage, it acts as mainly sedative. And
And then gradually, as we up titrate the doses, the action, the antipsychotic action is seen.
Oh, no. What are the distinct advantages of this particular drugs over clozapine or olanzapine? Any distinct advantages, if you know? Comparison with clozapine and olanzapine.
less side effects, sir. It causes less side effect than olanzapine, less
Which
EPS.
side effect you are worried about?
EPS, sir.
EPS. Clozapine is supposed to have the least EPS.
Or the
All the drugs.
bone marrow suppression caused by clozapine. The like quetiapine does not cause A
No,
granulocyte.
some other things, something else.
And it does not cause orthostatic hypotension.
No. Anything else?
Weight gain.
The risk
Weight
of
gain is yes.
metabolic syndrome
Yeah,
is much
that is
more.
the one of the major advantage you can have. You can say about this particular one.
Yes.
Okay. What kind of precautions you have to take when you give this drug in the elderly patients? Any particular things you are worried about?
And we have to do a ECG before starting the quetiapine in older age group, as it causes QT
Why?
prolongation in QT. It causes QT prolongation and erythema.
Okay. Okay. So that's all for this team. Next team we can have.
5, Dr. Rajvi and Dr. Anisha.
Let's have the next question.
Yeah. Yes, sir. I've just.
So, Drone,
Yes, sir.
shall I take over? Sir is there?
Oh,
Yes, Anisha and Parth, you are there. Okay, what are the advantages of using paliperidone or risperidone?
The QT prolongation
Hello?
is
Sir, paliperidone has no liver metabolism, and
Huh?
risperidone is metabolized by the liver. So, first pass.
Okay, you just tell me, paliperidone is a metabolite of risperidone or risperidone is a metabolite of paliperidone?
Paliperidone is the metabolite of risperidone.
The risperidone. So one metabolic pathway ahead of the risperidone. So obviously it would be more liver friendly. See, very simple. As far as the advantages are concerned about paliperidone and the risperidone, so here the Palaris is there, right? Long-acting injection is there, right? So let's compare the long-acting injection of paliperidone versus long-acting injection of risperidone. So what are the advantages with the paliperidone?
There is no need of giving oral supplementation for 3 weeks prior to giving the long-acting depot.
Nee,
In case of
Anisha, in all agents, right, in the you need to see whether the person has a tolerability for the drug or not. So whenever you are giving long-acting paliperidone or the risperidone, they should be either well tolerated with the oral paliperidone or the risperidone. That's the rule.
Yes.
So only advantages here would be risperidone you need to give every 2 weeks, while the paliperidone is a long-acting. You can give it once in a month.
Monthly. Yes.
Right? Chalo, what are the pharmacokinetics of its long-acting injectable form? So we have answered that question. What are the cardiac precautions are advised while initiating paliperidone? Any hint?
QT.
You can just guess, huh?
The QT prolongation risk is lower.
But much lower, right?
Lower, yes, sir.
Myocarditis?
So some incidences are there, but relatively it's very, very rare. So they are not considered as contraindication. Means unless there is a risk, the patient is a known case of some cardiac disorders, but otherwise the risk of all these problems are very, very low. Next slide.
Yes, sir. For team 6, Dr. Nikita and Dr. Isha.
Yes, sir.
Yes. So Nikita, what is the role of flupentixol in treating mild to moderate depression?
Flupentixol is used in combination with milnacipran for the treatment of mild depression.
Okay, my
Like
other
Explore is the brand in which one
Acha.
comes.
Flupentixol is a typical antipsychotic or atypical antipsychotic?
It is a thioxanthine. It is a typical antipsychotic.
Perfect. And how does it differ from other typical antipsychotics? You have already answered with that. You told me something regarding the combination.
Yes, sir.
Flupentixol plus melitrazine. So how does it differ with other atypical antipsychotics?
I'm not sure, sir. Sorry,
Any,
sir.
I'll give a hint. You know it because you uttered that combination's name. The antipsychotic dose of flupentixol when we use maybe a tablet of spenzo 1.5 milligram TDS, but you see the dose of flupentixol in that combination. It is very low, right?
Yes, yes, sir.
So
Dose
can you?
dependent effect
Yes.
on mood as well as safety.
So at low doses,
It
does it act?
acts as an antidepressant and anxiolytic.
Yes, perfect. So at low doses, it acts like a anti anxiety and antidepressant, while at a higher doses, it acts like a antipsychotic. What are the dosing recommendation for its depot formulation? It's already given in the picture.
It is available in 20 mg per ml ampule, and we give up to 40 mg can be given in one setting.
Yes.
And we
And
initially can give a trial.
yes. What is it called? Trial को क्या बोलते हैं?
Test dose.
Test dose. Perfect. We can. And what is it for? Why do we give test dose with the flupentixol?
To check for EPS or any other hypersensitivity reaction or allergic
Perfect.
reaction.
Who has answered this? Isha or Nikita?
I am Isha.
Perfect. Now, just a last question on this slide. Do we give test dose with injection paliperidone?
I
It
don't
is not
think so, sir.
needed.
Yes or no?
No, sir. I don't think so, sir.
Okay, so it is not recommended at all with any atypical long acting because getting a ampoule of a second generation long acting. Suppose you are getting Respiridon Consta at 5,000 and then break the ampoule, give the test dose, okay, and once person is not tolerating it, then return it back is a big problem. That's not a problem with the flupentixol. And theoretically it is not recommended at all. So we don't require to give test dose at all. So it's not a wise idea to do this with the atypical antipsychotics, long-acting antipsychotics. Okay, Drone, next.
Yes, sir. Team 7. Dr.
Team
Rishita,
7.
Dr. Ashish.
Yes, sir. I'm seeing NMDA receptor. So, sir, NMDA receptor sigma, can this be buprenorphine with bupropion with
Bupro.
dextromethorphan?
Yes, yes.
Combination.
Perfect. Now,
Because when it comes about NMDA receptor antagonist and sigma 1 receptor, that is bupropion's function, whereas when norepinephrine and also, no, that is sorry, sir. Okay, dextromethorphan's function is these both, whereas it comes to the bupropion, this is anketamine receptor, which is also an NDRI receptor inhibitor.
okay. Now,
So,
Rishita, you be very specific to my questions, okay? And don't be circumstantial as far as your answers are concerned. My question is very clear.
okay, sir.
We have the combination of bupropion and
Sir,
dextromethorphan together.
Sir, actually, the bupropion dextromethorphan combination is given because dextromethorphan is metabolized by CYP 450-26, and
Huh.
bupropion, which is an NDRI, it inhibits CYP2D6. So,
Okay.
so the metabolism of dextromethorphan is prevented by the bupropion, which is an NDRI, and hence they are
Perfect.
used in combination.
Hence they are it. So here main antidepressant is what? Bupropion or dextromethorphan?
Bupropion.
Bupropion. But
No, sir.
Rishita,
No,
we
sir.
have a
I mean,
huh.
dextromethorphan is the antidepressant, and
Yes.
bupropion helps with it, and also it helps in also decreasing. I mean, bio half-life of it increases because of it, and also the fastest mode of action is because of its combination.
Yes. So with your answer, I would like to convey to the all participants here. It's basically we have ample strengths of bupropion available, 150, 300, 450. Right. So here dextromethorphan is an main antidepressant, and half-life of the dextromethorphan is increased by bupropion by inhibiting its metabolism by inhibiting CYP2D6. Fine. So that's the mechanism of action. Okay, we can go ahead. We have discussed everything, Dhruv.
Yes, sir. Last one drug for the audience. This is lumateperone. It is a trimodal action with action on dopaminergic receptor. Serotonergic action is more, and also a glutaminergic modulation action is there. I've just kept it for the audience. Thank you. Lumateperone 42 mg once a daily dosing for bipolar depression and also for negative symptoms of schizophrenia. Next section, we'll move ahead with our faculty, Dr. Janvi ma'am. Ma'am will be taking neuroimaging specimen and neuroimaging and specimens. Yes.
Are specimens kept anywhere
Yeah. Yes, ma'am.
in
Like
exam?
it is in Sushil sir had asked me in certain places they are kept. So ma'am, I got a few 2 sections only.
Okay.
Yes, ma'am.
All right. All right. Let's go
Okay, ma'am.
ahead with neuroimaging.
Yes. Team 1.
Team
This
1. Who's that?
describe this team. Team 1 is Dr. Sarita and Dr. Parth.
Yes. Are they there?
Hello, Dr. Sarita, Dr.
Yes.
Parth.
Hello.
Yes. Okay, fine. Before we begin the questions on this image, can you tell me the role of neuroimaging in psychiatry?
Yes, ma'am. Neuroimaging helps to first initially rule out the organic causes, neurological causes of psychiatric presentations, which can be mixed up. So, first is to rule out the organic causes of the psychiatric manifestations, and second is it helps to confirm the uh, disorders. मतलब, when some neurological disorders present initially as psychiatric symptoms. So both ways to rule out and to diagnose also neurological disorders. And other is progression of disease. It helps to know the progression of disease based on neurological changes.
Can you give me one example where you advise neuroimaging? Can you give me an indication for a CT scan and an indication for MRI?
Yes, ma'am. Mainly, CT scan is used to rule out any hemorrhages.
Okay.
And MRI is mainly for any tumor or any other chronic changes in the. It is more useful in identifying that any space occupying lesions or any other abnormalities.
All right. So what do you see in front of you in the picture given?
Yes, ma'am. This is axial section of CT and CT scan, and it is in left side of the left side of section. Hemorrhage, मतलब hyper intensity is visible.
Hyper intensity. Okay.
Hmm.
What do you mean by that? I understood. Okay, let's go back. Why do you call it a CT scan?
Bone is white, ma'am. So
All right.
it is a
Okay,
CT
got
scan.
it. Left-sided lesion, I agree with that too.
Yes,
What
ma'am.
does the lesion suggest to you? I think just give me the
It is,
diagnosis. Let's not go into
ma'am.
hyperintensities. These are not
Yes,
hyperintensities.
yes, ma'am. It is possible of intraparenchymal hemorrhage, left side of.
Why hemorrhage? Okay. Why do you call it a hemorrhage? How would a hemorrhage look? I will tell you that this is an infarct and not an hemorrhage. And can you tell me why? Will there be a contrast? If it is a hemorrhage, will you need what will be the presentation on
Yes,
CT?
ma'am. I
Okay.
confused, ma'am. In
It's
hemorrhage,
okay. It doesn't
there.
matter. So you are very right that it's a left-sided. It's a massive lesion, as you
Yes,
can see, right? All right.
yes, ma'am.
So
Left side.
how would the patient present to you? It's a left-sided lesion and it is pretty huge, the infarct. So how would the patient present and
Yes, ma'am.
which
The
artery would
left
be
side.
affected according to you?
Yes, ma'am. It might be the MCRT, in fact, and patient will present with the symptom of right side hemiparesis and speech symptoms, and uh, the, paresis and
Yes,
paralysis.
agreed. Right, all right. And can you explain the blood supply of the brain in brief?
So mainly, ma'am, three major arteries: anterior cerebral artery,
Give me
middle
one
cerebral artery,
word, one phrase that gives the blood supply.
circle of Willis, ma'am. Blood
Right.
supply
So what
of.
all branches are there in the circle of Willis?
Ma'am, it is branches of AC and MCA. One is
Yes,
anterior communicating branches.
yes,
Next is anterior ICA and PICA, anterior
yes.
inferior cerebral arteries and posterior inferior cerebral arteries, and
And
branches from basilarly vertebral arteries
yes,
from
excellent.
downwards.
All right. I think our time is up, right? Rohan has shown the answer key.
Sorry. We'll move ahead with team two.
Yes, let's go ahead. But I think, yes, well done. Yeah.
Very
Second
well
team.
answered, examinees. Yes. Team two, please. Dr. Bhumi and Dr. Vipul.
Yeah, so what is it once again? What is the diagnosis?
Image of CT scan,
CT brain.
CT brain,
Okay, okay.
showing dilatation of ventricle.
There is a dilatation of ventricles. Okay, right. So what is your diagnosis?
Hydrocephalus.
Then
What kind of hydrocephalus? And can you really tell me what kind of hydrocephalus based on the presentation? Based on the image.
It could be normal pressure hydrocephalus.
Why do you say that? What is the description given to you? Radiological report suggested an Evans index of more than 0.3 with urinary incontinence. I think even if you don't know what an Evans index is, I think what is important is the urinary incontinence, which is the symptom. And that helps you in diagnosing in a way, right? Why normal pressure okay, what do you mean by normal pressure hydrocephalus? What are the symptoms or how does a patient present?
there are three cardinal symptoms: urinary incontinence, ataxia, and altered consciousness.
Mm-hmm. What about dementia? So it is dementia, urinary incontinence, and gait. That is the Adams triad. What kind of dementia? There are two types, right? Well, I'll ask you the difference between reversible and irreversible, which itself is a clue.
In this case, it is reversible
Reversible
dementia.
dementia.
Yes. Why do you say it is reversible?
Because when hydrocephalus is remitted, it will revert the changes of dementia.
How will it remit? On its own?
No.
So what do you do?
By procedure,
What procedure? Agreed. By
CSF
procedure.
training.
How?
Operate
CSF draining. Yes, and you can put a shunt. Very true. So the symptoms will revert if it is diagnosed early. Unfortunately, many times NPH is missed somehow. And then there is a problem. Then the process of cognitive impairment may become irreversible because by the time it is diagnosed and the patient is treated, it is too late. And then the atrophy also sets in. Then there is a problem. All right, let's go on to the next one. Anything else?
No,
This
ma'am,
is a CT scan actual view. You can see the dilatation of lateral ventricles. That is the most obvious thing. But did you also notice the cerebral volume loss and therefore suggestive of normal pressure hydrocephalus? And we also saw what the triad is. Next one, please.
Yes, ma'am. Team 3, Dr. Pratik, Dr. Riddhi.
Yes, what is it?
MRI of brain.
Okay, why do you say it's an MRI?
Because bone is black.
Bone
And
is
it
black.
is a
Okay.
T1 weighted MRI.
Mm-hmm.
As white matter is a
Why T1? So what are the different films that
sorry
you get?
T2
One is
weighted because CSF is a white and
okay. So what are the types? T1 you mentioned, T2 you mentioned, and the third one is
flare.
Flare. Okay, what do you see on this MRI?
Hemorrhage
Where?
in a right side hemisphere
Mm-hmm.
and subdural hemorrhage.
Okay, subdural hemorrhage. Or is it extradural?
Ab- above the dura.
So if it is above the dura, what will it be called? Okay, let's presume, okay, there is a hemorrhage accepted and is it pressing on the brain tissue? What will be the presentation in the patient? Can we have the answer, please?
Yes, ma'am. Ma'am, I've not put the answer. This is subdural hematoma. MRI
Okay.
presentation.
This is a subdural hematoma and not extradural hematoma. And what will be the clinical presentation of the patient? Will he be present with a
Headache.
Headache.
Will he present with vomiting?
Confusion, memory impairment.
Yes, could be. Very true.
And there is a
Agreed.
mass effect also seen. Yes, ma'am.
So
We'll
there is a pressure effect seen, and therefore there will be signs because of that also. Okay. All
we'll
right.
move ahead
Chalo.
with team 4.
Next. Yeah, let's go ahead.
Dr. Soneri Shanchi and Dr. Maitri.
What is this?
So this is the EEG, electroencephalograph
Mm-hmm.
sheet, and
So what do you do? What is meant by an EEG?
So, ma'am, it records the electrical activity of the brain.
Okay, and how do you do it?
We do it by applying various leads across various positions over the scalp, and
Mm-hmm.
we measure the potential difference between the leads, and then it is reported
By
as
leads, you mean electrodes?
yes, ma'am.
Okay. So you measure the potential difference between either two electrodes or
referential,
Or one reference electrode
one referential lead.
and
yeah, so a neutral point on the skull and an electrode, and an electrode placed on the brain in so that you get the potential difference between those two. What is meant by 1020 International System of Placement of Electrodes? Because that is the standard system that is
yes,
used,
ma'am.
right?
So, ma'am, in
And
1020 system, we divide the skull into from the nasion to inion, and
Hmm.
so from nasion to vertex, we divide it into 10 and 20, and then from vertex to inion 2010.
So there are unipolar leads and bipolar leads, right?
Yes, sir.
Okay. What is the advantage of a bipolar lead or bipolar montage, let's say? Which is for better localization of a lesion. Can you tell me the background activity on the EEG that you can see on the slide?
in background activity, there is a 9 waves frequency in the occipital region. So most probably it is the alpha rhythm
Did you say 9?
background. Yeah, yeah, ma'am.
Is it 9 or 9? Is it? It's always a range, remember.
Ma'am,
Your
Yeah.
activity,
So
background activity is
activities,
never an
background
absolute
ma'am,
number.
activities.
9 to 11 hertz is the frequency. There are predominantly
Correct.
sharp waves we can see in the background.
Sharp waves in the background itself. So the background activity is the activity that is existing or the basal activity, and all the abnormal waves like sharp waves and spikes, they are superimposed on your background activity. And therefore, background activity is if the frequency is 9 to 11 hertz, what kind of a wave pattern is that?
Alpha rhythm.
So when do you get alpha waves on EEG?
Ma'am,
Uh,
normal
when
awake
the
EEG with
normal
eyes
awake,
closed.
but the eyes are closed.
Right.
Yes.
Suppose a patient is lying down, awake and with eyes closed, and you're recording alpha activity, and the patient opens his eyes, what happens?
So
That
the
is
activity is
artifact.
converted into we can have artifacts. More than 13 hertz activity we can have.
No. We tell the patient to open his eyes, and the patient has opened his eyes. Can you see it here? Patient has opened his eyes. And then what happened to him? What happened to the background activity once the patient opened his eyes? Is there any difference between this background and this background? Can you, I'm sure
Yeah.
you can't see
Yes,
my
ma'am, it has
cursor.
Yes, ma'am.
it has
Yeah.
become slower.
Has it become slower or
No, no,
faster?
sorry, ma'am. It's become faster. Sorry.
So what is it known as? That the activity is responsive to eye opening, which is a normal phenomenon. Okay. Which is the other normal wave pattern that you can see on the EEG in front of you, which is fast. That's a hint.
Beta activity,
So what is
which
the
is
normal frequency of beta activity on EEG?
more than 13 hertz.
More than 13 hertz. Right. And when do you get beta activity?
Active attention when
Active
the
attention.
hmm.
What else? Do drugs induce beta
Uh,
activity on normal
Yes,
EEG?
ma'am.
Which
yes, ma'am.
drugs?
Yeah.
Commonest.
Ma'am, melatonin.
Okay, then
We can
suppose
also
you do
see
an
the
EEG of a patient who is being treated for
Benzodiazepine.
alcohol withdrawal. What kind of
Benzodiazepine.
so
benzodiazepines will give rise to fast activity? And there are a number of drugs, including your anti-epileptic drugs, that give rise to abnormalities in wave pattern on EEG. It's good to know what changes it causes in EEG. Okay. All
Very
right. We can go
Yes.
ahead.
This was a normal EEG. Thank you. We'll move
Correct. Do
ahead
we
with
have an answer to this? No, no.
no, ma'am.
Okay, fine.
We move ahead with the next team, Team 5.
Okay. I think this is a simple one. Is it not?
Yes, ma'am.
Yes, tell me. What is it that you can see?
Dr. Rajvi, Dr. Anisha.
Absence.
First of all, identify the wave patterns. Abnormal wave patterns, not the normal.
Absence seizures, spike in wave, 3 hertz frequency seen generalized across all leads.
Yes,
Suggestive of an
that's
absence
very
seizure.
right. So what abnormal waves can you see in this?
Ma'am, what I said that there's a spike in wave
Yes,
pattern.
so there are spikes and slow waves. So what is the description of a spike, a typical spike? Can you define a spike?
A spike is a wave less than 70 milliseconds in.
Right. How do you calculate that 70 milliseconds on your EEG?
So typically it's less than 1/3 approximately of a smaller division within a second.
Yes.
Is what
So
we
1/3, your division will be of about, see the darker markings that you can see, they indicate 1 second, right?
Yeah.
So if you divide them in 5 quadrants, it will be 200 milliseconds. Why is it essential we know where 200 millisecond is?
because
Which other wave are you going to? Yes, your sharp, which is between 70 to 200 milliseconds, right? All
Yes.
right, let's go on to absence seizure. So when you describe an absence seizure on EEG, you're also supposed to describe the duration for which you observe it. Okay, because that's the duration of the episode that the patient suffers from most of the times. And therefore, when you say that this is a characteristic 3 wave per second pattern, you also need to say whether it lasts for say 5 seconds to 7 seconds. And it is always a range. Remember, it cannot be an absolute figure. What is the treatment of absence seizures and how does the patient present?
Ma'am, it is typically noted that there are sudden lapses in attention. There are no tonic-clonic movements noted, but the patient typically loses attention or does not remember what happened. So teachers or parents usually notice such episodes.
So if
That is
the
how-
child is reading something, he would just miss a line and go ahead.
Yes.
Right?
Yes.
Something like that. All right. How do you treat it?
Valproate and
Well, it is shown here in the slide. It's valproate and ethosuximide.
Yes.
Now, more so, valproate, ethosuximide is not really available. Okay. Okay. Chalo, next. Well done.
Thank you.
Team 6.
Oh, yes. What is this? Complicated, isn't it?
This is a 10-20 montage of electroencephalogram recorded in the longitudinal. It's a longitudinal montage. Is it a burst?
What is it?
Is it hips arrhythmia?
No.
Burst
Okay, now
suppression.
tell me, you can see that collection of waves very dense on the right side, right?
Yes, ma'am.
What does it suggest to you? Where will you get something? Can you really make out the wave pattern in that?
No, ma'am.
All right. When do you get this kind of activity? I think we need to show the answer probably.
Ma'am, it's GTCS.
Yeah. Actually, uh, I concentrated on the right side. It does look like an artifact actually. But the left side of the graph, which is showing an abnormal pattern. Uh, so what kind of a pattern is this on the left side?
Yeah, ma'am.
Nikita, right?
Yes,
Nikita
ma'am.
and yeah. So, okay. What is the abnormal pattern that you see?
Multiple spike and wave pattern is seen.
All right, so the spike and wave pattern. You must realize that left side of the graph shows that, and the next slide also shows that. But the particular pattern that you see on the right side, it looks like a muscle artifact, where you see multiple high voltage activity which are clustered together. Okay, so your typical muscle artifact will also look more or less like this. But as you have correctly said, there is a spike and wave pattern which is suggestive of a generalized tonic-clonic convulsion. So, how do you treat a generalized tonic-clonic convulsion? What are the drugs that are preferred nowadays to treat the GTCs?
Valproate, ma'am.
The first thing that every neurologist starts.
Levetiracetam or
What are the
brevaciracetam.
disadvantages of levetiracetam?
It can
It
cause
can induce
behavioral problems.
psychosis.
It can cause behavioral problems, and therefore one can replace it with.
Valproate.
Can you give brevaciracetam?
Yes,
Yes,
ma'am.
levetiracetam.
Brevaciracetam.
You can also give brevaciracetam, right? Brevipil, Brevera, somebody has written in the chat box. Okay. Suppose a patient of alcohol dependence comes in the casualty and there is history of seizures after stopping alcohol 2 days ago. Do you start anti-epileptics? And what is the reason for seizures in that case?
We don't start anti-epileptics in such case.
How will you determine whether the patient needs anti-epileptics or not?
We
If
can
he has
order a EEG, ma'am, to rule out any pathology.
Like, so are there any conditions in the same patient which will prompt you to start an anti-epileptic? In short, what are the causes of seizures in alcohol dependence?
head injury,
Yes, head injury. You need to rule out head injury. And the second cause, which you presumed is the cause when he had a seizure 2 days later?
alcohol
Withdrawal.
Withdrawal seizures,
withdrawal
right?
seizure.
So you need to differentiate between a withdrawal seizure and a seizure which may have been caused by head injury that the patient may be suffering from, or why not idiopathic seizure disorder also. So you need to differentiate between the two and then only make a decision about anti-epileptics. I think our time is up, right?
Yes, ma'am.
Yes. All right.
Table
Okay. So we
7.
go on to pathology specimens. I hope you don't get pathology specimens for your exams. Okay. What does it suggest? It
Okay,
suggests
it was
for me
it is
also.
first 7, ma'am. The first one is cerebral vascular amyloidosis. and the second one is of a dementia with the vacuolar enlargement and a
I think the
probable
second one
syncopal.
is pretty obvious. You can
Yes,
make
ma'am.
out the dilatation
Dementia.
of ventricles and the sulcal abnormalities pretty clearly. Somebody has also concluded it is Alzheimer's. Okay. It's for the audience or for the team?
Ma'am, it was for team 7, but that's okay, ma'am. This
Mm.
two for
No,
the
we can ask
audience.
questions, no?
No, this is
Forget about it
okay.
is cerebral amyloidosis. What about forget about the specimen. You can tell me something about cerebral amyloidosis. Team 7.
Team 7.
Amyloid that is the basically they get deposited in the cerebrum. Amyloids are the
Yes,
beta
agreed.
plated sheet. Amyloids are the beta amyloids.
Okay.
Um,
What happens to them? Is it the same as Alzheimer's?
Ma'am, in amyloidosis, you have these A beta amyloid inclusion.
Okay. I think you need to know a little bit about cerebral amyloidosis and also about amyloidopathies that are there, and even other proteinopathies that are there, like tauopathies. Okay. At least a little bit about these abnormalities you should know. The typical post-mortem appearance of Alzheimer's disorder also you should know, in case you are shown a pathology specimen where you are supposed to identify. Okay. There is only one more question that is relevant in neuroimaging, and that is what is the difference between structural and functional neuroimaging? I think people need to know a little bit about that also. Thank you.
Thank you so much, ma'am, for your such an insightful and patientful conduction of the exam. Thank you, ma'am.
It
Two
was a
EGs.
pleasure interacting with students
Yes.
and with you too, Drone.
Thank you, ma'am. Two EGs for the audience. EG 1. Anyone? We'll move ahead quick.
Is it myoclonic jerk, sir?
Yes, good. Very good. It is myoclonic jerks, which is characteristic of juvenile myoclonic epilepsy. Okay. This. And I
Can
think
I
one of
ask
you
a
have already.
question along with that?
Yes, ma'am, please.
Suppose there are periodic myoclonic jerks like this. What is the differential diagnosis? Is the
CJD,
question any
ma'am.
more than CJD? Yeah, CJD is also there, but it
And
is,
then
let's say, a
SSPE.
periodic mirror image like, what is it?
SSPE, ma'am,
Yeah,
subacute
SSPE also, yes.
sclerosing
Yes, very right.
panencephalitis.
Yes.
It is caused by what?
Measles.
Measles paramyxovirus. Yes, good. Thank you. And the last one, I think one of the examiners already mentioned. This is Hips arrhythmia, that is infantile West syndrome that has salami seizures, salami spells. Okay. Thank you so much, Dr. Janvi, ma'am. Dr. Ashish, sir.
Thank you.
Thank you,
Can I
ma'am.
log out?
Yes, ma'am.
Okay. Thank
Thank
you
you so
so
much,
much
ma'am, for
for
your time
inviting
and
me for
kindness.
this.
Thank you so much for your
Thank you
time.
so much.
Thank you, Sushil. Thank you, Abhijit. And all those I could see Sri Lakshmi and Romesh also. Yeah, bye-bye.
Bye.
Dr. Ashish, sir. Dr. Sushil, sir
Okay.
is not here.
Yes. We will go ahead.
Yes, Sushil sir will be the the faculty for this session. Yes, we move ahead quickly with team 1.
Team 1, Parth, right?
Parth and Dr. Sarita.
Sarita, be quick. Chalo. What is this?
Yes, sir. Yes. Easy. This is EEG monitor.
EEG monitor. What?
And it is the ECT machine.
Yes. So I can completely empathize with, because we have a different models. In our college, we have
Yes,
EEG
sir.
monitored ECT
This
machine, but
is
now there EEG is on the laptop and the ECT machine is connected to that. This is a portable type of the
Yes, sir.
machine. I completely agree with you. No worries about that. Name the 4 phases of seizure monitoring as seen by the EEG changes following ECT administration. Are you aware about that?
First is, sir, tonic phase, and
Yes.
and we deliver the shock.
हाँ,
Afterwards is the um afterwards it is
टोनिक हो गया.
tonic-clonic movement.
उसके बाद
हाँ,
कौन सा रहेगा? एक टोनिक हो गया,
tonic-clonic movements.
क्लोनिक हो
Yes,
गया.
sir.
हाँ, उसके बाद
And sir, residual fasciculations in the
हाँ,
end of the part.
हाँ. And after that, post seizure what happens? Means after depolarization के बाद ब्रेन का क्या होता है?
Uh,
Post seizure slowing of the EG activity, right?
slowing, yes, sir,
हाँ,
slowing.
हाँ,
Yes, sir.
slowing of the EG activity. So 4 phases are there. What are the cognitive side effects to monitor?
Sir,
Obviously, it would be of ECT. Nothing would be of the EEG. Huh.
yes, yes, sir.
Yes, Sarita, fast. Which cognitive side effects we monitor?
Sir, we will monitor retrograde amnesia, anterograde amnesia, autobiographical memory
Yes, yes. So we
with the
with
help of
which? Okay, so we do pre-ECT one scale and post-ECT. What is that
yes,
scale?
yes, we can basically MMSC. We can start from
Uh,
MMSC. Other scales are also there.
okay. So basically, cognitive side effects, है ना? Amnesias, MMSC before and after. A third question: name some anesthetic agents used in ECT. दो बता दो बस.
The main yes.
Pardon, Sarita? I think you are
Sarita, you are
muted.
not audible.
Huh.
It's okay,
Thiopental and
Dr. Parth, you
propofol.
can.
No,
Propofol
sir,
and
thiopental and
Thiopentone
thiopental,
sodium.
which
Yes,
we
thiopentone
yes,
sodium
sir,
and propofol are commonly used.
propofol. Yes,
Okay,
sir.
Drone next.
yes, sir.
Well done, Parth, Sarita, well done.
Team
Thank you.
3, Dr. Pratik, Dr. Riddhi,
Yes, sir.
what are the various cognitive functions and what are the batteries, side effects of prolonged
Uh,
seizure?
Battery for okay, can use battery for ECT cognitive. Uh,
Okay. Then what are the side effects of prolonged seizures?
then cognitive
Temporary
impairment
cognitive
in
decline.
headache,
हाँ,
back pain,
हाँ. अरे more serious.
disorientation,
More.
हाँ, yes. And what we worry about?
confusion. Sorry.
We worry. See, if someone has a prolonged seizure after ECT, we worry about one thing that is very, very serious, where we need to take patient from the.
Dislocation of teeth or
अरे नहीं, patient
tongue bone.
can land up into status epilepticus,
Yeah.
right? Alright, so that's the risk, right? Okay. Chalo.
Cardiac arrest is the risk. Then the
हाँ,
batteries is before ECT recode. Nimhans has again remodified it. Okay. Team 2,
yes, team 2. Who is there in team 2?
Dr. Bhumi, Dr. Vipul.
Bhumi and Vipul, come on the platform. Very, very simple question for you. Bhumi, are you there?
Yes, sir.
Okay, Bhumi, just identify the equipment. Which is this procedure?
TMS.
It is instrument for transcranial magnetic stimulation.
Perfect. RTMS it is. What is the mechanism of action?
It creates electrical activity from the
हाँ,
brain in the brain
हाँ.
via magnetic stimulation.
Okay. Which is that current named as? वो current का नाम क्या है? Electrical current, magnetic stimulation generating one electric current. AD is current, right?
Yeah.
Okay, okay. Mention FDA approved indications of RTMS.
For depression,
Depression,
Okay.
second.
OCD.
OCD,
Third, तीन है indication ना? Depression, OCD and third is smoking cessation.
Okay.
Okay.
Nicotine dependence.
smoking,
हाँ हाँ चलेगा. Next we'll
Team 5, same, it is the same specimen type. What are the
yes.
type of coils, adverse effects, and various frequencies, and what is their indication?
हाँ. So who is there in team 5? Vipul.
Rajvi and Anisha.
Rajvi, Anisha, come on the platform.
So there is a 8-shaped coil which is used for OCD.
Figure of 8. It is called figure of 8 coil. One is
Figure
that.
of 8 coil which is used for
And which is
OCD.
this coil? Which is this coil?
So I don't remember the name, but it is used for
Single
depression.
coil.
No, this coil which you could see in the image. What is this?
The single coil.
Pardon?
Circular coil.
Single coil.
Okay, fine. What
Then
a
H-shaped coil which is also
yes. So figure of 8, circular coils, H-shaped coils, and
double cone.
I could not see the, but I doubt this is not a circular coil. This is butterfly coil mostly. Okay.
150-degree angle, sir.
Because if suppose there is elevation in the center and bending on the both side, it would be butterfly coil. Okay. So mention the adverse effects of RTMS.
Back discomfort, tingling sensation, headache.
And yes, all milder side effects.
Fatigue,
One serious side effect.
sleepiness,
One
seizure.
serious.
Seizure.
Yes.
seizures.
Yes. Perfect. Absolutely. What is the role of using varying frequency?
A high frequency can cause inhibition of the brain
Okay.
area, and a low frequency stimulation is used for activation of the brain area.
Are you confusing yourself? ये vice versa तो नहीं है?
high frequency for
Is
excitatory effect
excitatory.
and low frequency for inhibitory
Low
effect.
frequency, inhibitory effect.
Perfect. So, Rajvi Bhumi, please clear your concept very clearly. If we have a hallucinations and if we need to suppress the neuronal activity, you would require low frequency. While in case of a depression where you want to activate the prefrontal cortex, you require high frequency, right? So simple principle, low frequency to inhibit, high frequency to stimulate. Chalo, Drone, next.
Yes, sir. Team 4, Soneri Ishanchi and Dr. Maitri, please.
TDCS machine.
Yes. What is the mechanism action?
So it produces, so it supplies direct current stimulation.
Okay.
And
Mechanism action is electrical stimulation of the neuronal cells.
yes.
Okay. Which psychiatric condition have shown benefit?
So depression.
And we have one case, recently published case report of role of TDCS in one indication from Manipal in our IJP.
So, PTSD, catatonia.
Okay. Again, the same like RTMS. We have one report from India that is for smoking cessation from Manipal. So they have a study about that. So depression, smoking cessation, anxiety. What are the typical current and duration used in session?
So 0.8 to 1 ampere current we give.
Okay. Now I'll ask you three conditions. What is the constant current in ECT machine? In ECT machine which we use, what is the current we use?
1 to 4.
Bolo. Nothing wrong.
In ECT, so we use
In
alternating
ECT
current.
machine. How much? In ECT machine, we have a 800 milliampere current, right?
Yes.
Now you tell me what is the current in earthing shock which we get at home, है ना? अगर कहीं पे हमारा हाथ लग गया, we get earthing shock, right? अर्थिंग शॉक लगता है ना घर में, हल्का सा शॉक लगता है, उसको में कितना होगा? So it is 0.5 to 0.8 milliampere. Now tell me the current used in TDCS कितना होता होगा यहाँ पे? So just
500 to 1000.
no, that would be too high. It is 1 to 2
1 to 2
milliampere. Okay, 1 to 2
1 to 2.
milliampere is
Okay.
used. So always remember अर्थिंग का करंट से थोड़ा सा TDCS का करंट ज्यादा है, ECT का करंट बहुत ज्यादा है. That's the reason
Okay.
portable devices are available. Okay, next, Drone.
Team
Okay,
6.
which is this equipment? Next team.
Team 6.
Biofeedback.
Yes.
Yes, biofeedback machine, right? Biofeedback relaxation machine. What is the principle?
We give certain relaxation techniques or principles, and we ask the patient, and we monitor the live physiological parameters that are there. So that acts as a reinforcement.
Okay, so which physiological parameter is there in biofeedback relaxation machine?
Heart rate,
rate,
Heart rate.
muscle, muscle
We
tension
put
respiratory
can be
rate.
measured, temperature.
we put electrodes or fingers, right? In
Yes.
biofeedback relaxation machine. So why do we do that? It is for which physiological parameter?
Respiration, oximetry.
Have
Sweat,
you
measuring the
have you heard about GSR? What is GSR?
gal
Galvanic
Skin resistance.
galvanic skin resistance, right? So when you are anxious, there will be more opening of sweat pore. So galvanic skin resistance will be reduced.
Decrease.
है ना?
Yes.
So it works on the principle of our autonomic nervous system, whereby there are changes in a galvanic skin resistance. During anxiety, galvanic skin resistance decreases. When we are relaxed, galvanic skin resistance increases. Okay, third question. In which conditions it is useful?
Phobia.
anxiety disorders.
Okay. Whoever said phobia, it is not actually used for phobia. It is particularly to reduce down the anxiety, generalized anxiety. Then those who have just anxiety traits, or those who have a anxious type of the temperaments. So anxiety disorder is one, but in anxiety, particularly for the phobia, it won't be useful. Okay. For the phobia, you would do exposure therapy. You may use as an adjunct to reduce down the anxiety, but not a particular treatment of, suppose somebody has a claustrophobia and you are using biofeedback relaxation machine for claustrophobia is not there. So it's particularly for the anxiety, to reduce down the anxiety. Okay, Drone, next.
The last team. What?
Sir, is it not
Last team.
cortical
Pardon?
electrical stimulation, sir?
Wait. I'll read the first question. What is the principle of functioning of an alcohol breath
Okay.
analyzer?
Okay.
Sir.
Yes.
Yes, Rajesh. Ashish and
Rishita.
Rishita. Huh.
So the principle of alcohol breath analyzer is the Henry's law, that it's that for the diffusion from the pulmonary capillaries to the alveoli of alcohol of ethanol occurs, and we measure that in the breath, and the legal permissible blood alcohol concentration level is 0.08%. That is 80 milligram per deciliter of blood alcohol level.
That is too high. It is
It is
0.03.
too high. It
But
was
in
there
India, it is
before.
0.4, sir. It is.
Even.
Sorry?
Sir, in India, if I'm not wrong, it is 0.4 or
It is 30, that is
30 milligram per 100
0.03%
ml, 0.03%.
of
0.03.
BHC.
Okay, not 0.04.
No. And
See,
the
Ashish, this was there in the book, in the older textbooks. Okay, 80 milligram per deciliter. That was for the older, in the older textbook it was there. But now amendments are there.
Yes,
So
sir.
30 milligram per 100 ml or 0.03%.
Yes, sir.
Okay, huh.
And the principle is infrared spectroscopy or an electrochemical cell detection from the
Yes.
breath.
Yes, yes,
Okay.
yes, yes.
These are the
Question.
there are many new portable devices. I have put some of them. One is Alpha Steam and one is Cephali.
Sir, so the alpha stim can it be cortical electrical stimulation, sir?
Alpha Steam is it is for electrical stimulation for anxiety, insomnia, and
Anxiety
depression.
and depression.
Okay.
And when it comes to
Cephali, it is for anxiety and migraine.
anxiety and migraine. All right.
Okay.
Okay, sir.
Any idea about role of trigeminal nerve stimulation?
Sir, trigeminal nerve stimulation, can it be with this implanted, you put a pulse? Okay, sir, I'm not completely sure about it, but it is for treatment resistant depression where you can use this. And
Depression and
epilepsy.
anxiety only. It activates the locus coeruleus via the V1, V2 branches
Vagus.
of trigeminal nerve.
Yes, sir.
Okay. Thank you, sir.
Yes, yes. And that portable neuromodulation devices, FDA approved for depression and anxiety?
Sir, these are this Alpha Steam and
Alpha
Cephali.
Steam.
Yes, sir.
And
We
that
have a
SOMO, na? SOMO, TDCS.
yes, sir. SOMO and they are giving a TES device. There is one
Yes,
by
yes.
Visor, that is Enhances made developed, and other
Yes.
is this home TDCS device, sir. They
Home
give it at home.
TDCS devices approved by US FDAs.
Yes,
It is
FDA.
called as some SOMO or some
Somni.
terminology. Yes, yes.
Somni and Fisher Wallace stimulation.
That is approved. Yes.
Yes, sir. Sir, I have a few poll for them. Sir, if
Okay.
I'll just give the vote of thanks, sir, if the faculties want to leave, sir. I mean, should I display the poll now or should I give the vote of thanks, sir?
No, okay, you can display the poll, no problem.
Okay, no problem. Okay. This is the poll for the audience and the participants. Is it visible?
Yeah, it's visible.
Can you answer the questions, please?
First answer is
Yes.
a sanguine form board.
Can you click on the screen or something? No?
No, sir.
No, sir, we
Yes, sir,
can't.
we can click.
Yes, it will be possible to click on the screen, please. I want everyone to answer real quickly.
First, you haven't looked.
It doesn't click.
Sir, it doesn't click, sir.
Okay, I'll then anyone wants to answer the question?
Sir, the first one is sanguine form board test.
The first one is Bhatia battery of performance test. Okay. For the second question, most accurate for executive function in patients of schizophrenia versus the frontal lobe lesions?
Bent.
Tower of London and Alexander Fascinating.
Yeah, it is Tower of London and Wisconsin card sorting test.
Yes.
22-year-old male of schizophrenia shows periodic sharp wave complexes every 1 second on
SSP.
EEG. Yes, very nice. This is subacute sclerosing panencephalitis. It's not febrile seizure or absence seizures. The appearance of 3 Hz spike and wave pattern.
Absence seizure.
Absence.
Yes. So the answer here is childhood absence epilepsy.
Childhood absence epilepsy.
Yes. Which psychotropic has shown sigma-1 agonism contributing to its antidepressant effect?
Fluoxamine.
Fluoxamine. There is also for sigma-1 action is also there for dextromethorphan.
Yes.
Okay.
Yes.
Yes. Question 6. A patient with bipolar depression is on lamotrigine to minimize the risk of SJS. What is the recommended titration schedule?
Option B, sir.
B, sir.
25
Okay. Yes.
mg.
Start 25 once daily and then
weekly.
increase weekly. Coming to the section of neuromodulation in TMS, what is high frequency?
B, sir, equivalent to electroconvulsive therapy.
Excitatory to cortical. So TMS high frequency more than 50, usually 10 and 20 Hertz. So we give high frequency to the left DLPFC, and we give inhibitory, that is low frequency 1 Hz to right DLPFC as per the theta bus protocol.
Okay.
In conventional TMS, we give only to the left DLPFC, high frequency excitatory. Okay. Question 8. Most consistent EEG abnormality?
Wide QRS complex.
Wide QRS complex.
Oh, I'm sorry. Yes. Yeah, it is widened QRS complex. Okay. I think I can share the results. Okay. Thank you so much, everyone. As we come to closing the today's enriching session, I would like to give a heartfelt thank to our eminent faculty, Dr. Sabu sir and Dr. Janvi Kedare ma'am, especially Janvi ma'am for their time, insight, and kind mentorship. My gratitude to the IPS West Zone Office Barriers and to the Education Committee Chairperson, Dr. Sushil sir, for his unwavering support, and Dr. Abhijit Fire sir, Honorary Secretary. Thanks to all the PGs for their active participation, and to all the viewers on Zoom for taking part in this wonderful academic journey. I hope this Viva, this session was really helpful to all of you. Dr. Sushil sir, your closing remarks, sir. Thanks. Hello, Dr. Sushil sir.
I think sir has got logged out, bro.
Okay,
I
ma'am.
can't see his name. No issues. On behalf of the West Zone PG Education Committee, really like to thank all the participants. It takes a lot of guts to come up like this online in front of a lot of people who are watching you, which is very unlike an exam actually. But because you guys came, there was a lot of learning that happened. So faculty definitely for the patient listening and guiding, and you guys, hats off to you for being there and having the courage to stand up. We are in process of making certificates for you guys. I think your participation needs to be given the acknowledgement it deserves. So thank you. There will be more events coming up, so you can all stay tuned to the WhatsApp group, where the link for today's program will also be shared so that you can go back and visit and do some more learning. And any further updates will also be there. So thank you so much. And Drone, you did an amazing job. I think previously we've had 4 different people handling 4 different tables, but
Yes,
you were
ma'am.
a one-man show today. So great job. Thank you so much, everyone, and have a great remaining Sunday.
Thank you so much, ma'am. For all the PG participants, I'll share your certificates in the WhatsApp group. Thank you so much, and always remember, feedback is the fertilizer for growth. Thank you so much for your active participation, and thank you, everyone. Have a good Sunday.